Yes, Hiram, and good morning to everybody. Thank you to the organizers of this conference from the Kalangos Foundation, Dr. Kalangos, and also my deep gratitude to Sadhguru Sri Madhusudan Sai. It's a very interesting conference to be at. I'm very grateful for the opportunity also to Dr. Sean Shetty and all the other organizers here. This topic is a very advanced topic. Even the topic is looking very complicated. I need to decipher it to you first, because we live in a world of artificial intelligence where even in this room constantly, this conference is being transcribed using artificial intelligence. AI is on our phone. But the latest form of artificial intelligence which is relevant to cardiac surgery is agentic AI. And I want to take you back in time to tell you what is agentic AI, right? As the word has two parts to it, agentic and AI. Agentic AI is something which had its early foundations actually in the mid-20th century, where you had these concepts of cybernetics, so science fiction, concepts like intelligent agents, you had these, literally Hollywood movies which talked about robots and autonomous things moving around, which became a reality, closer to reality with expert systems in 1970s, 80s, where expert surgeons like each one of you here in this venue and listening online could actually, simulate reasoning systems of humans, where you would have very rigid, pre-programmed paradigms which will mimic human decision making. The third aspect was the rise of, in 1990s, the intelligent agents, where an agent could act within a controlled environment. For example, a factory. You could see this in automobile industry. You could see this in manufacturing. Then you had advancements in 2000 of, neural networks, where the human brain was simulated in computer programming. And you could do even deeper analysis. You saw, games like Gary Kasparov, the then chess grandmaster, being defeated by computers designed by IBM, etc. And the 2010s saw the rise of autonomous robots. You actually saw physical autonomous robots moving in a factory floor. Now, what's all this got to do with cardiac surgery? In the last 25 years back, I think Intuitive Surgicals came up with Da Vinci, which did not pick up really, but today they are the market leaders. Here in India, in this hospital, we are using an indigenous robot called as SSI Mantra, which helps to do precision cardiac surgery. But more importantly, the recent rise of generative AI. All of us are carrying AI in our mobile devices. So agentic AI is basically artificial intelligence, where unlike artificial intelligence, which is programmatic and which is just helping you decide something or recommending. For example, many of you leaving today evening can ask Google, and Google is using AI at the back end, or you can use ChatGPT to plan your entire next week, saying that you're going to leave this hospital at so-and-so time, this is your next week's schedule. It's only helping you with reasoning. But what agentic AI can do is real-time act in a way where diagnostic accuracy can be increased. For example, you have multimodal data when it comes to cardiac surgery, CT scans, MRIs, X-rays, and identifying many anomalies and abnormalities with high precision is something which agentic AI can not only interpret and recommend, but it can also learn and function independent. I'll show you how. Second is, most importantly, post-operative personalized treatment plans. Agents can monitor real-time visits to the doctor, gather data, be a mobile app on the phone of the patient who's got discharged. I heard today from Dr. C.S. Hiremath that a patient who underwent recent robotic cardiac surgery had an infection and had to get admitted back. How do you follow up? How do you know about this till the patient himself or herself comes and gets admitted to surgery? So agentic AI can play a role. Also in early disease detection. I can see in this room, many of us are wearing smartwatches, right? It's all constantly monitoring our heart rates, doing a lot of stuff. What if this is integrated with interoperable devices inside the operating room? So I've spent more than 5 minutes just explaining the topic, but my focus is going to be how autonomous surgical planning and real-time adaptive intra-operative guidance can be achieved using agentic AI, right? And I represent a company which is actually based in Texas, Austin. I'm the CEO for Middle East. And I'm happy to tell you that, in fact, our platform is also given totally free of cost for this hospital. So This matters now because today the anatomical variance, more than 87% of patients, despite very accurate CT scans and all of that, and certain intraoperative decisions which are arising, for example, using a Da Vinci or SSI mantra, it's no longer a cookbook surgery. You're also seeing, that in a lot of cases, when you have multimodal data, look at angios, CTs, recon maps, every millisecond matters. And agentic AI can play a role in giving both software-based agentic and haptic feedback. Haptic feedback is built into the Da Vinci robots, it's built into that. But it's still not linked to agentic AI. You're only getting precision in maybe navigating to do the incision and to do parts of the surgery. But there's really no real-time feedback from an agentic software which can work with the robot and make it not reactive but adaptive. So also there are micro errors which can happen. For example, submillimetric drift when you're seating a valve or a reconstruction of a leaflet. And this could lead to coronary perfusion or certain other outcomes. So the bottom line here, or the problem statement which agentic AI can solve, is not only relying on human plus robot in the cardiac surgery, but also bring in agentic AI or agentic intelligence. So AI, we say artificial intelligence. Harvard Business Review said augmented intelligence, where you have human plus robot. Agentic AI is bringing adaptive intelligence, So it's a combination of all these three. The core components of this, if I look at it, there is a surgical state memory which this agentic AI software can build. So based on the scans, you can build maps of tissue elasticity. You can also calibrate and store some of the device responses when you do a robotic cardiac surgery. And you can also look at calcification stress zones. So some of these things can be stored within the agentic AI metrics, including instrument kinematics, which is very, very critical when it comes to robotic surgery. The second aspect is multi-objective surgical planner. So where you can use surgical art, you can use patient-specific functions. When I say patient-specific cost functions with respect to the cost of, the surgery of, with respect to the health condition they have. So today, the robots are not autonomous. They help you plan the path. But you can also see how you can tie back some of these feedback in terms of angle, pressure, torque to the agentic AI software. Now here is the most interesting part, the autonomous tool use layer. So today you have multiple interfaces when it comes to robots, imaging consoles. So how do some of these things, beyond human capability to navigate these instruments, how can an autonomous tool layer be built on that? And last but not the least, how can I build a kind of a 3D model for the patient, which shows live in the software, blood flow dynamics, almost like replicating a digital twin of the patient who's being operated using a robotic surgery. So here I present to you a concept, the digital twin surgeon, right? So if I have some of the multimodal data, if I have the tissue mappings, if I can do the CFD, and I can also possibly integrate heart-lung machine. In fact, I'm happy to inform you that under Sadhguru's vision, we've also built an indigenous heart-lung machine in this institute. We made a first of its kind, made in India, affordable heart-lung machine. And how can I use agentic AI also to pre-surgery plan some Monte Carlo simulations, right? What is the minimum risk catheter path? How much of incision I should do? So what is the coronary flow preservation angle? All of these things, not only based on the surgery which is happening, but surgeries which have already happened, which are recorded using conversational AI, which I'll come to a little bit later. And then looking at device-person interaction, simulating that in terms of ring recoil, how the tissue rebounds and all of that. So you can actually come up with what we call as an ACB, an adaptive contingency blueprint, which can actually predict proactively what are some of the risk pivots, create alternative pathways, and basically reduce even the surgeon's fatigue and also his cognitive burden by almost 70 to 80%. Now, conversational AI, I know working with some of the cardiac surgeons here, especially Dr. C.S. Hiraman, in the Indian Association, we document a minimum of 27 pages of information of what happened in that surgery. What if I could come in a surgery, and within the surgery, right after the surgery or during the surgery, I could dictate to my mobile device. We are actually doing this in the conference. I'll show it to you a little later at the end of all the sessions, maybe post-lunch when we decide. But what if during the surgery, the patient can actually, sorry, the doctor can actually speak to an agentic AI software on his phone, describing the entire case. So by the time he comes out of the surgery, he doesn't need to document this again. It's all captured, it's all documented, and the entire surgery report is ready. And also a pre-scientific publication material is designed by artificial intelligence. Right? Of course, we'll have to check for plagiarism, we'll have to check for errors, we'll have to, obviously do our due diligence. The other aspect of it is also understanding, using what we call as NLP. Cardiac surgical vocabulary is complex. So NLP is natural language processing. So how can you understand, interpret, classify, demarcate some of the complex vocabulary, especially when it comes to publishing papers? And also anticipating real-time risks, as I said, and then using voice plus augmented reality and holographic integration, right? So also, most importantly, what if projection? Surgeon can actually ask the agentic AI, what if I do this by so much percentage? And instantly, the cognitive conversational AI responds that the risk of, increasing the stent pressure is basically increasing the annular tear by 4.2%. So continuously, it's no longer just an independent robotic device, an independent surgeon and his team working. But there is an agentic AI layer which is actually connecting all three of them and making them work together. So in the interest of time, I'm not getting into this, but this is a proposed architecture, how we can have an input layer. The intelligent core is where you bring in the agentic conversational AI. And then you have an output layer, which hopefully, working with SSI Mantra, we want to do this, build robotic actuators which can do those micro adjustment and also give safety cues and predictive warnings in addition to what, almost think of it as a third eye to the surgical robot, which is constantly guiding the surgeon and also learning in the process. Today, the biggest drawback of any robot, including Da Vinci, is that it doesn't learn. The robot is not learning. The surgeon is not learning. But agentic AI layer built on top of this surgery using a continuous learning loop will learn from every maneuver, refine it in the digital twin model, and enhance future planning. So I'll share this PPT in the interest, but we'll also have to look at some of the ethical and strategic, transparencies, which we'll have to, because this is a new benchmark we are bringing. We need to train it on global diversity. We need AI surgeon credentialing. So which means surgeons like you need to be trained also on the basics and fundamentals of agentic AI and be transparently informed of the risks which go with some of these things. So we'll have to combine safety, ethics, and performance. So we're having a roadmap to this where we have already built a prototype of this. We want to now integrate it with the robotic surgery, hopefully working with Dr. Sean and all of the other experts and the foundation, and look at how using, we call it supervised autonomy in complex segments, especially complex surgery, and move to, in 5 to 7 years, to a fully agentic surgery. It's not that the surgeon is not there. Just like in a robotic surgery, surgeon is also there. In an agentic AI, also there will be a surgeon who is there for any fallback option. If something goes wrong, he can step in for the manual intervention. But can we, in 5 to 7 years, using agentic AI, truly move to AI executing the entire procedure with human supervising the intent boundaries and the final approval? So this is going to have a transformative effect. Of course, it needs global standardization. It's going to lead to lower mortality. But I think it's going to reduce a lot of preventable technical complications, especially in intraoperative cardiac surgery. That's all I had, and I want to end by saying that we stand at the dawn of no longer AI, but cognitive surgery, where true intelligence, artificial and human, is working together. And intelligence, this combined augmented intelligence, is a new scalpel, right? So that's all I had. Thank you very much for this opportunity. Thank you.
Thank you very much for the wonderful presentation. If there is some questions?
It was impressive because there is continuing challenges through, this artificial intelligence. If I understand well, with this artificial intelligence, one day we will ask the intelligence to do the surgery. It would be possible, this one. Because, you will reinforce the precision, especially the surgical. You will minimize the human error. Yes. But how to prepare? It means, we have also give all the tools to artificial intelligence to planify and execute the surgery. How to achieve this one? You have the patient. You have, for example, a VSD, a hole to close.
Yeah, I think it's a great, I'll just keep it brief, but it's a great question. We are not yet there, and that's why I gave a roadmap of 5 to 7 years. The robot is already there, which is doing part of the surgery, but still human supervised. So it has to be, as I said, Agentic is bringing the integration of software to bring autonomy to the surgery, still with human supervision. I would never exclude human supervision, especially in a heart surgery, because the fault tolerance is, if something goes wrong, the patient dies immediately, right? So we'll take an offline conversation, but there is a way to basically move to a roadmap where if today 25% is being done by the robot using a Da Vinci or whatever, SSI Mantra, how can we build a software layer which is giving feedback not only to the surgeon, but also to the robot and enhancing the robot's learning? So I think in the next 2 to 3 years, we can move to almost 40% of, partially autonomous surgery, still with the surgeon standing there. But I think full autonomy will take some time. It will take at least a decade more.
Yes, and my second question, one of the problems with robot was, the tactile sensation. This one was a big handicap. Is not possible, to feel the fragility of the tissues.
Yes.
Especially, and
Correct.
ask, the robot, especially with its arms, to be more careful.
Yes.
Recently, I reoperated a case which has undergone previous mitral valve repair, and unfortunately, the aortic valve was completely harmed during, the implantation of the mitral ring. This one is a big evidence that there is still, and it was, a new generation of robot. There is still a lack of this.
There's a lot of micro robotics we need to build.
Tactile, yes.
Yes, you're right, because it can't just happen with the current robots.
Yeah.
In fact, some of the things we are working on in collaboration with this institute is also, for example, building anastomotic stapler devices, right? It's not just the robot at the surface, but it has to be something which goes in right to the tissue level and does things. So, thank you so much.
Okay,
Great
thank
question.
you.